Okay. So, how's everyone? How are you, Anam? Aisha, Kuratulan, Ishaq, Manikam,
Ramadan Mubarak.
Rushna, Ramadan Mubarak. Thank you. Rushna, Sabah, Shinta, Vidhi. How are you guys doing? Shaista and everyone. I hope you guys are doing good. Yeah. Walaikum Assalam. Annie, how are you doing? Okay, okay. Navona. Okay, great. So, hi Rushna, hi. Okay, so we are going to, they do discussion on the teaching task. But before that, because many candidates have requested me to just give an overview of upcoming exam. Okay, so I will just quickly go through the pattern of exam because after this May exam, we are going to have the November exam, right? And after November exam, we are not going to have the February one like we used to have for the last, the couple of years. So this time we are just going to have May diet and then November diet. And there are 99% chances that November exam is going to be face to face. Okay. So because now they are increasing number of centers all around the globe. And along with that, they are like, kind of almost according to the MRCOG, the chapter in UK, they are saying that 99% chances are there that the exam is going to be face to face. Okay. The May exams is going to be the only diet in which they are going to cater online OSLR as well as, the face to face. Right. So let's start, guys, because we will discuss a very interesting session after that. And so let me just quickly go through the pattern of part 3. So we will quickly skip it and then we are going to discuss. So I need a volunteer as well. So make sure that you volunteer yourself or I will choose it myself. All right. All right. So this is the RCOG building, Union Street, London. Okay. Very beautiful building. And I hope every candidate wants to go there. And this is really prestigious, kind of in a way that, of course, you are going to be there for your convocation. And after that, you are going to be awarded with your membership, the degree. Then the total 4 attempts are there for part 3. You have to attempt part 3 within 7 years of passing part 2. For the candidates, who have passed their part 2 long ago, so it is very much advisable that they have to attempt at least once. It doesn't necessarily mean that they have to pass. All right. They just need to attempt it to secure their part 2. Otherwise, passing part 2 is another hassle. But sooner the better. Okay. As long as you are, finishing your part 2, it is very much advisable by all experts that, go and attempt part 3. Because as you are, as much as you are going to delay, the syllabus is going to be vast, many new things are going to be added, and who knows the pattern, they might change the pattern as well. So day by day, they are increasing the difficulty level of this exam as well, and keeping in view that exams are going to be face to face. So yeah, that is another challenge. All right. So make sure that you are, the attempting it. And aim of MRCOG is to assess a candidate's ability to demonstrate core clinical skills in the context of the skills, knowledge, attitude, and competencies. Right. So because part 2 is purely theoretical, however, part 2 is theoretical, but part 3 is going to be combination of your clinical, the skills, competencies, and of course your applied clinical knowledge as well. And nonetheless, it's the final step in becoming member of prestigious Royal College. So this is a basic structure. Everybody should understand that what is the education and the specialty training system at NHS, right? So I will just, tell you guys that how system works in NHS, because more of almost 90% of us are overseas candidates. So you should know that there are, the 2 years foundation year training. Then there is going to be basic training, ST1, ST2. And RCOG expects that after ST2, a candidate must have finished their part 1 MRCOG. Then they will enter into their core training, which is going to be ST3, ST4, and ST5. And after finishing ST5, RCOG expects that candidate must pass part 2 MRCOG and part 3 MRCOG, both. Okay, so by the time they are going to finish this part 3 MRCOG, they are going to enter into advanced training in which they can choose their, the specialty and all. However, for the candidates who are overseas, when we are going to become MRCOG, so this is the way in which we are going to pass our English language exam. Okay, so MRCOG along with OET, you are going to be eligible for GMC registration. After getting this GMC registration, you can apply for jobs. All right. You can apply for jobs all around UK, and the level what you are going to get is, is going to depend upon that, what are you applying for. Basically, again, everyone suggests that, if you are going to UK, because you are going to change your system, all right, you are going to enter into, the a very different system. All right. So you might be selected for ST1 level, ST2 level, and the ST3 or ST4. ST3 is going to be, the basic intermediate training, the job which every MRCOG candidates wants to enter in. All right. So make sure that, whenever you are going to aim for it. So of course, it doesn't matter if you are working as a specialist consultant in your own respective countries, but when you are going to start your career in UK, you are going to be selected at this level, or this level. All right. So don't expect that you are going to be at this level directly. No, not at all. So you can just imagine that, the foundation year training, this is similarly like our internship or house job, what we do in our countries, right? Then they will enter into, the training program. So 5 years training program. And from upgradation from 1 year to the other year, they are going to have couple of, the landmarks which you have to achieve. Okay. I'm sure all of you must have read in part 2 OSETs, right? So they are going to have their yearly OSETs, they are going to have their yearly, the assessments from their respective supervisors, and then they are going to be, the upgraded from year 1 to year 2, and so and so. All right. So make sure that, when you are aiming for MRCOG, you have your everything clear in your mind. This is one route to enter into NHS, and the other system is PLAB route. PLAB is relatively, the very junior one, because this is only the license exam, right? After doing license exam, you will be chosen as foundation year training. So make sure that when you are, the even rerouting, or when you are trying to, the enter into the system, so you are having your, the clear concept about the systems. Okay, one route is doing MRCOG, the other route is PLAB itself. After doing PLAB, you are going to do your house job again. Okay, you are going to do your 2 years again, foundation year training 1 and foundation year training 2. All right, and when you are going to become advanced training in ST6, ST7, then you are going to choose your subspecialty, then you are going to do your advanced teaching, the specialty modules as well. All right. So make sure that you have your everything clear in your mind. And apart from that, even if you want to practice in your own country, so yes, MRCOG is going to give you a very, the I must say advantage over, the 1 degree, whichever, the country are you, the practicing in. So of course, it is going to be an additional point, and of course, the very, I must say, a star in your, a very beautiful feather in your cap. Okay. So this is going to be, the training, and this is how MRCOG is going to help you to enter into NHS. Then curriculum of this part 3 is very vast. So you will have your, the CIPs, okay. Then you are going to have your, the all, the CIPs, and they are going to design your, the training accordingly. Level 1, level 2, level 3, level 4, and level 5. Level 1 is going to be only observer, okay? And level 2 means that you are going to act under direct supervision. Level 3, when you are going to act under indirect supervision. Level 4, when you can independently with support. And level 5 is going to be when you can do any procedure, any, the kind of operation or anything independently. Okay, so these are going to be, the level of descriptions. Then capabilities in practice is going to be ST1, ST2, RCOG, or you can say NHS has made, the certain criteria, which I have told you, right? The doctor is competent in recognizing, assessing, and managing emergencies. So ST1, ST2 should do that. Okay, so the basic stuff, ST1, ST2 should know that. And ST3, ST4, then there are going to be the couple of other procedures as well, like endometrial biopsy, cervical smear, insertion of IUCD, vulval biopsy, surgical management of miscarriage, basic hysteroscopy, diagnostic laparoscopy. So it will start from year 4, right? So by the time you are going to finish your year 4, year 5, year 6, you are going to achieve level of competencies, and then of course you are going to be signed off. All right. And once somebody is signed off, then only he and she is capable of doing any procedure there is. Otherwise, you cannot touch any patient without having your competencies signed off. All right. So this is, I have taken everything from our SOGI, the website. So if you guys are interested, you can even download everything, and then, you are going to, see yourself. So we do have formative assessment and we do have summative assessment, right? So we all are aware of that, what exactly the formative assessment is when we don't get any kind of result. But yes, we are going to be judged on our performance, our activity, that how we behave, how we do, and this is how we are going to improve. However, MRCOG is going to be summative, right? So in this, you are going to either pass or you are going to either fail. And once you are going to fail or pass, so of course you are going to upgrade in your, the education journey. So MRCOG journey, basically, you need to pass your part 1, you need to pass your part 2, and then you have to prepare part 3, which is now. You have to start preparing for your part 3 now. If you are aiming for May exam, which I'm sure, the many of you must have filled your, the exam, the form or something, and you must have gotten the seat as well. So after that, even if you are, the aiming for November, so yes, start preparing for it now, because it takes time to enter into the flow. It takes time to have a good grip on the schedule as well, right? So for the exam, there are going to be 14 stations, right? One is going to be SPT. Usually we call it as simulated patient task. And then there are going to be structured discussion tasks. There are usually 7 to 9 simulated patient tasks. In simulated patient tasks, you are going to get, the role player. Okay, role player mean you are going to face, the simulated patient. Okay, but those are going to be professional actors, right? So you are going to get all these role players, and then you are going to be talking to them, and the behaving like a doctor, like we do deal in our own clinics, right? Then structured discussion tasks are going to be there as well, the second form. And in this simulated patient task, then we are going to have simulated colleague task, which we are going to practice today. Simulated colleague task mean then we are going to see our colleague, in which we have to talk to him or her. Either we have to teach anything, either we have to describe anything, either we have to help him in his training or something. Okay, so this is going to be that. So 5 or 7 are going to be structured discussion, 7 to 9 are going to be simulated patient. And at one time in 2021, they had 7 plus 1, 7 plus 7 as well. So this way you can see that this is not all about the good English speaking. This is not all about your good knowledge. So it has to be balanced, right? So you have to revise your curriculum from part 2, important stuff. And always remember, this is applied clinical knowledge we are worried about, right? So we don't have to narrate our 60, 80, 100, 200 pages guideline to any the examiner there is. All right. So we have to study in terms of that how we can be the help this patient in our real life, if at all, if we see. All right. So you have to manage. So make sure that you are working on both tasks. All right, because I have been teaching for like quite long now. So what I have noticed in my the teaching career, that everybody wants to do role player task. Very few candidates want to practice structured discussion. Trust me, structured discussion carries very good marks. If you are very well versed in your guidelines and your talk articles, and you are doing structured discussions in a very structured way, trust me, there are high chances that you can get the full marks. So what is the harm? What is the harm of working on your all guidelines and talk articles, rather just being interested in role player tasks? Okay, so from now onwards, make a habit that you give equal attention to structured discussion task and the simulated patient task as well. All right. Then, of course, pattern of exam is going to be 2-minute reading time. And for May exam, there is going to be online. So 2.5 minutes in online, half minute is for switching, 10 minutes is going to be the inside the cubicle, that is going to be performance time. So we have said earlier, and when you are going to talk with the role players, out of them, 3 or 4 are going to be with lay examiners. Lay examiners means they are going to be the random people. They are going to be either from HR, either lawyer, either teacher, community worker, anyone. They are going to observe. They are going to observe you as a, the person, as a doctor, in terms of your communication. That can be your physical communication, your, the expressions, your, the choice of words, the way you speak to the patient, the way you behave. And for example, there are going to be certain stations which may be, the sensitive. For example, you are seeing a transgender person. For example, you are seeing same-sex relationship. For example, you are dealing with vaginismus. For example, you are dealing with any the sexual assault case. Okay, for example, so they are going to see you. They are going to see your expressions as well. That, I mean, do you get alarmed? Do you get, the kind of any kind of bad expressions? Do you really feel the pain of the patient? Do you really feel what a patient is going through? Are you showing any kind of, the remorse, or are you showing any kind of expressions towards patients as well? All right. So they are going to judge those. If they are going to judge, those, so of course, those stations are going to carry highest marks. Okay. So make sure that, your communication is very flowy. You are choosing very, the proper and the nice sentences. They don't need fancy English, the heavy dictionary words. Okay, they just need good communication in terms of that you are choosing, the very easy sentences. We call it as patient friendly language or jargon free language. All right, so make sure that you are reading your patient information leaflets as well. Some of the stations can be linked stations, and there is no rest station. However, in online exam, after 7 stations, there is going to be rest for about 15 to 20 minutes. So you are just going to sit in front of camera. You can't move, you can't go to loo, you can't eat anything, you can't drink anything. You can just sit there. Okay, just sit there and wait for the next 7 stations. However, in face-to-face exam, there is no break at all. So total 168 minutes and it's over. In online exam, time can be more because we are dealing with technology, we are dealing with internet, we are dealing with anything. So anything can happen. So there can be chances of rerun of a station. Okay. So maximum 2 to 3 reruns can be allowed to one single candidate, provided that you have a valid reason and the committee, the exam committee who is observing you, the technical committee who is observing you, giving you, the rerun. Then for November 23 exam, like I have told you that this is going to be face-to-face, 99%. In online exam, it is going to be video conferencing, like we are talking, but our cameras are going to be on. So we all need an internet system, that's it. And you must have a browser, Chrome browser installed. Everything, every permission would be given to the, the Osler system as well. So on the day of exam, you will enter into one system. You will be given a very unique ID, and you are going to log in. You are going to have your system check, video, audio. You are going to have connectivity, your Wi-Fi quality as well. Then you will get this window. All right, you will enter into the system. You are going to wait for yourself. Then your time will start. 2 minutes. Remember, you don't have to log out until and unless you finish your exam. All right. So you are going to be in that system. You don't need to go anywhere. You are just going to enter into the system with the given IDs, right? Then in 10 minutes time, you are going to perform, and this circle will repeat for 14 times. And then once you are done with your 14 stations, you will log out. Simple. All right. So this is how it will look. You are going to see, the such type of Osler system. You are going to see the questions, you are going to see the timer as well. So don't worry about it. Everything will be in front of you. And this is how you are going to see, this is role player. This is, the role player this is role player. This is role player. This is examiner, candidate, and everything will be in front of you. In face-to-face exam, this is, we all are well versed of, right? So I mean, we have been dealing with these kind of exams throughout our life. So one after one, you are going to move from station number 1 to 2 to 3, 4, 5, 6, and so on. And this is how you are going to see a couple of, the papers outside pasted on the door. Okay. And then you are going to enter into the cubicle. Face-to-face exam is going to be a little bit noisy because the cubicles are very small, and the 14 cubicles are going to be side by side. You may overhear the candidate which is in the next cubicle, the cubicle next to you. So make sure that you are concentrating, and you are not concentrating on that, the candidate's exam, the exam what he or she is talking about. There is no rest station. And then you are going to talk in front, in terms of domains. And I'm sure everyone of you knows about the domains. Domains is where your exam is going to be judged. Information gathering. In our, the what we practice in our countries, we call it as history taking, right? History taking. It's same. In here we say information gathering. Then of course it is going to be coupled with communication. If you have good communication skills, you are going to take good history. Then applied clinical knowledge. Remember, this is applied. This is not, the theory, what you study in part 2. And patient safety. This is what, the every station will be judged on. Patient safety is a kind of, you can say, a hallmark of every candidate there is, because NHS wants a very good, safe, practicing doctor. Okay. So remember, 14 tasks will be assessed between 3 or 4 of the domains. Okay, but communication is going to be there, safety is going to be there on every station. So how to succeed in part 3? Look confident, appear as a safe doctor, be logical and organized. Sure, you show some kind of sympathy towards patient as well. Like patient is telling you, doctor, I'm having this pain. Oh, I will come to you after that. Okay, doctor, I have been through a lot and I have had a lot of pain while I was dealing with this. But you are into your history, and you really want to finish that, your history template. So you're not going to pay any kind of heed to that patient's pain. So this way you are losing your 1 point. Okay, so when anybody is showing any kind of pain, any kind of the problem, so I mean, address it there and then. Oh, I'm so sorry that you had to be, you had to feel this way. I'm so sorry that you had to go through this way. It must have been horrible. It must have been painful for you. I understand. It is quite understandable. Okay. So this is how you have to, to show some kind of, sympathy to the patient. Use simple and understandable language in a polite tone, and change your character and enter into another station when you are going to switch to the other station. And reasons to fail part 3, very, very valid reasons. Yeah. So failure to have a persistent and consistent daily practice, believing the myth that knowledge will not be tested, believing the myth that this is pure knowledge test or just communication skills, right? Like I said earlier, that many of you really want to practice just communication task and they don't want to practice structured discussion. However, in my opinion, you need to practice more on structured discussion task, because this way you can carry, the solid marks. If you are very thorough in your knowledge, if you are, dealing with all these stations quite nicely, so there are high chances that you can get, 10 on 10 marks in that station. Using too many jargons and relying on courses and material gathered from here and there. Don't rely on anything. This is your exam. Okay. Maybe what I have, the practice in my exam, it was completely different than what you will practice in your exam. Okay. So yes, courses can help you, courses can guide you, material can guide you, but don't mug up them. Okay. Don't memorize them. Don't memorize anyone's line. Okay. You yourself are unique. You can show your own uniqueness. You can show your own sentences, because everybody speak, different way. And we all have very, the somewhat, the different, you can say, the speciality in terms of, the so many things. Many of us are very good in communication. Many of us are very good in applied clinical knowledge. Many of us are very good in both. Okay. So try to find out what is the strongest part in you and try to work on that. Okay. Don't follow herd. Just make sure that you are working on yourself. Try to improve on daily basis. Don't rely on ready-made templates can help you, but templates cannot give you, the any 100%, because nobody is RCOG. Nobody knows what will come in exam. Trust me, sometimes stations do look familiar, but when you enter into the exam, you will see the agenda is quite different. Role player will behave quite differently. The questions are going to be different. The key, to mark that station is going to be very different. So don't think of that, the college is that stupid that they are just going to give you the stations and then that's it. No, there are going to be, the couple of hinges in that station as well. Okay. So sometimes it looks very familiar. So what the difference is going to make is that you are, the practicing on daily basis. Okay, so you have to practice on daily basis. You just need to work on yourself, and please believe on yourself. You have come this long way. You have entered into this part 3 journey now. Okay, you have finished your part 2. All right, so don't think that you cannot do it, and don't be overconfident as well. Oh, come on, this is nothing, I will just do it like this. Okay, trust me, all of us had to do a hard work. I had been, a very good student throughout, but I had to work hard in my part 3 as well. I have failed it once and then I have passed it. All right. So it doesn't matter. And passing any exam in first attempt doesn't make you a very good candidate or a superior candidate. Okay. Maybe it is, your good luck. Maybe because you were very well prepared. Maybe your circumstances were different. Maybe, the anything was there. But the failing any exam, even it doesn't make you a very bad candidate. Trust me, if you give your 100%, and even if you fail after that, then it's okay. Then maybe it's hard luck. Then maybe it's not your time. All right. So, but don't just the look at those people who have passed their exam in first go, and then they try to they shun you down that okay, look, you just need to pass in first go. No, no, no. RCOG is not going to ask you after passing an exam. Nobody is going to ask you, I mean, for how many attempts you have tried for this exam, and in which attempt you have passed this exam. Okay, so make sure that you are not the underestimating yourself, your ability and everything. um Walaikum assalam, Mahroof, good to have you. I hope you are doing good. Hmm? So how much time is enough? Usually, if you give your sincere time, if you give your sincere input to any exam, so I strongly feel, because I've been through a couple of exams. In fact, the 4 boards exam, half of my life been through this exam. So I mean, if you give 3 to 4 months study, dedicated to study to any exam, so I think there are fair chances that you can pass any exam. Okay, but make sure that you are giving your 100%. Rest, of course, nobody knows what is going to be in the result. Okay, so the road to success and the road to failure are almost exactly the same. Remember, okay, the road to success and the road to failure are almost exactly the same. See, when we watch any film, we do get the two kind of roles. One is hero and one is villain. So who decides who is going to be the hero and who is going to be the villain, although we are watching the same movie? See, the difference is going to be the character. Difference is going to be that the correct or the focus guidance. All right, in terms of when you have to pass this exam. Okay, so this is very much necessary that you need the a kind of good guidance that you have been given, and you are having a sincere the kind of input in terms of that when you are practicing the stations, and somebody is guiding you through, somebody is pointing your weaknesses and you're highlighting your strengths as well. Because when you are the traveling into any kind of the path, so of course we need to know that what are our strong points and what are our the weak points. So we have to work on weak, and we have to the keep consistency in our strong points as well, right? So this is what we are going to the do. We are going to start our November batches as well. There are going to be a couple of the mentors courses, one-to-one courses as well, and we are going to take the one-to-one course with me. If you guys, anybody is interested, so you guys can book with me as well. You guys can book with other mentors as well. We do have the very brilliant mentors, other mentors in med exam expert, Dr. Uzma Alim. We do have Dr. Muhammad Hassan. We do have Dr. Helmi. We do have Dr. Maryada now. Okay, so we have a very good faculty. So anyone can be your mentor, and anyone can guide you to pass this exam. Okay, so we are open for the November batches as well, and for the May exam, we are starting our booster course, and it is going to be started from 3rd of April. And Dr. Maryada is going to be doing the rapid revision. So all of you guys are encouraged, to join it. It is very with very reasonable, the fee as well. So I'm sure it is going to help you guys. Okay. Plus, apart from that, the mocks are open with me and for May exam and November exam as well. Uh, okay, so this is how we are going to cover. So what exactly part 3? So we have said that this is combination of your knowledge and communication skills. And then in terms of domain, you need to talk about information gathering. Information gathering is history taking. It should be in order, it should be crisp and directed, it should be jargon free, and it should be focused. All right. So you can see that, in how many points you have to work, right? Jargon free. To remove these jargons, you have to cover your patient information leaflet. So once you are going to be in order, so of course your history is going to be crisp and directed towards the presenting complaint only. You are not going to fulfill your own template, okay, the ready-made template, or you can say the template for certain module, but rather you are just going to be focusing on presenting complaint. That's it. So patient information leaflets are going to help you in that. And then you need to take the history of presenting illness, past history, family history, gynecological history, drug history, history of allergy, personal history, socioeconomic history, mental health questions as well. Then what sources you can use: NHS choices, patient information leaflet, RCOG patient information leaflet. You can the watch couple of videos on YouTube, Vimeo channels. Applied clinical knowledge, use recommended sources. And what are our recommended sources? TOG articles, NICE guidelines, Green Top guidelines. Communication with patients and colleagues, it is going to be very good. Okay, it has to be very good because you have to work as a team. You cannot do anything on your own. Okay, remember that when you are dealing with any patient, you are going to say that I would do that, I would do that, and with the help of the other team members, we are going to cover like this. Okay, multidisciplinary team approach is very much important. So there are going to be the couple of things which are going to be judged: communication with colleague, multidisciplinary team, consultants, midwives. Make sure that you are sending, if the patient is referred from GP, you are sending patient to the GP, anesthetist, and the so and so. So this is how you are going to do it. Then patient safety. Patient safety is going to be like name, age, pregnancy, living status. In case, if you have to offer her any kind of social support, last menstrual period, BMI, smear history, safe medications, alcohol, smoking, recreational drugs, history of allergy is very much important. If you have to give her treatment and if you haven't inquired about allergy status, so yeah, you can be in trouble. You want to prescribe her with penicillin, but she is allergic to penicillin. You want to prescribe her with metronidazole, but she is allergic to metronidazole. Okay, so allergic history is very much important. Then in 2 minutes task, what you have to do, remember all of you May candidate and even November candidate as well. In 2 minutes task, you have to read your task carefully. You have to check what domains are tested in this task. Don't start making keys. Okay, check it's a referral letter or no. Formulate how you will start the station. Read questions again and again. This is very much important. So you are not going to miss anything from your the question. If a question is a huge and there are so many things being told in that question, you are just going to cross check them. You are not going to tell her patient that I understand that you are having this headache for the last 3 months and I can see that you are here and you have taken this. No, you're not going to tell her that you had this. You are just going to pick the last line from here. You are going to say that, hello, I can see that you are Jennifer. So I can understand that you are here to discuss about your management because you are having this epilepsy. Am I correct? Okay. You are not going to tell her the whole, the history which has been given in this, the question. Then in 10 minutes time, of course, you are just going to look at the role player. You're not going to look at the examiner or anyone who is, the present in cubicle. You are just going to finish your task with the respective domains. And in the end, you have to close the loop. You have to start, you have to check GP referral, you have to perform your task, you have to write back to GP, you have to give her PIL, and you have to thank her as well in the end. Okay. And remember, if it is not a breaking bad news station, and if it is not that bad station, so you can simply, they say good morning. You can simply say that, the good morning, good evening, or something like that. Okay, good afternoon, whatever is your time, the zone at that time. All right. So make sure that you are closing the loop. Then how to do the preparation? Organize yourself, plan, make a schedule, look for a good study buddy. If there is no study buddy, okay, doesn't matter. Okay, practice with yourself. Make templates if you really can. Otherwise, the practice with your mentor. If you have taken any course or any help, do all available stations in books according to your feasibility. Then you can, the book any kind of courses. Curriculum is same as part two, right? We do have teaching module, core surgical skills, post-operative, gynecological problem, sexual reproductive health, subfertility, early pregnancy care, antenatal care, postpartum care, maternal medicine, management of labor and delivery, and clinical governance topics. Sometimes some modules can overlap. Okay, so this is how RCOG makes their 14 stations. So what are the books to be done on priority? This is Lisa Joel and very recommended book. Then Oxford Specialty Task, Tony Hollingsworth. This is Get Through and Justin Cooney book. You can practice, the stations available in all these. If you have, the study buddy, so well and well good. You can practice 2 to 3 stations a day. One time you can be a role player, other time your friend can be role player. So this way you can rehearse as many questions as possible. So in today's session, we are going to cover teaching module. So in this module, you should follow, the proper scheme. You are going to identify the level of your, candidate, okay, level of your training, build up a rapport. You are going to start, okay, you are going to start your station. Then you are going to start with theoretical part. Sometimes if at all it's a kind of teaching station in which you have to study the theory, uses, indications, contraindications. You are going to allow candidate to interact with you in a very the you can say that in a very familiar way. In the sense, you are going to make a good rapport. You are going to start your station and then you are going to tell him, the involve him. You are going to involve him. After telling him some uses, you are going to ask, can you repeat some uses for me? After doing indications, can you repeat some, the indications for me? If he repeats, the very nicely, okay, you are going to give him, the a very smile, the half smile. You are going to say, very good. Okay, you are going to tell him that, very good, you are a very good learner, thank you so much for the learning this quite nicely. Contraindications. So you have to they get him engaged in few steps of teaching stations, all right, but not in all parts. Then, for example, if you are in face-to-face exam and if you have been given any mannequin, if you have been given any kind of the thing to perform on, so you are going to ask him to perform couple of the initial steps, but not all steps, because then it's going to be very challenging as well. Invite the candidate to do the steps himself, check understanding and satisfaction of the candidate, offer later on other learning resources like workshops, web research, courses. Ask candidate to give you feedback, and in the end you are going to thank him or her. Then you are going to tell him, the good luck in the training and all. Usually in exam, what do we get in teaching module? Usually we do get ST1, the junior level, ST1, ST2, or some. In my exam, I have had the MRC GP training. MRC GP training, because in GP training they do have to rotate in, like, I mean, 2 to 3 months to every the specialty, so they have to learn everything. Okay, so I have had this MRC GP training and I had to teach him tertiary insertion. So yeah, so whenever you get the any junior, so make sure you are not going to address him, hello, I'm ST5, and you, no, you are going to say, hello, I'm Dr. Hi, I'm Zaid, and you, hi, I'm Farah, and you, hi, I'm this and this, and you, okay. So make sure that your the tone is very friendly. You are the interacting him in a very the good way, that he won't feel the hesitant while he will talk to you. And he will tell you, for example, if it's a case of bullying and undermining, if it's a case of the anything which is bothering him, if it's a case of any the kind of assault, if it's a case of anything which is involving his mental health. So this way or that way, you have to make a good rapport. And once you will have a good rapport, then only one will open up. Otherwise, nobody will open up and will tell you the problems. All right. So I hope everything is clear so far. Any question, guys? Any question? No question? Shinta, Siti, Shaista, Sadia, Namona, Maruf. Any question? No question? Okay, no problem. So who wants to perform station? Maruf, would you like to try, or Shaista? Would you like to try a teaching station with me? Aisha, Fozia, Hanatu, and who is there? Rushna, or anyone who wants to perform station? Hmm? Nobody? Trust me, if you're not going to perform, you're not going to learn. Okay? Otherwise, attending the sessions is okay, but make sure that you are attending in a useful way. Shaista, are you there?
Yes, ma'am, but
Hmm? Why don't you try?
yes, ma'am.
Try it up, okay?
Right, ma'am.
Will you try? Hmm?
Yes, ma'am.
Okay, brilliant. That's good. Okay, so let's discuss our teaching module. You are going to take your 2 minutes, and this is task for you.
Can I start, ma'am? Yes, ma'am, I'm ready.
Okay, let's start. So make sure that you start your timer as well for 10 minutes. So this way you will have the clear check that where are you lagging behind. Okay?
Yes, ma'am.
Okay, great. Let's start.
Hi. 1 minute, ma'am. Hi, I'm Shaista, and you?
Yes, I'm Andrew. Hi,
And
doctor.
you? Yeah, Andrew, nice to meet you.
Nice to
Uh,
see you, Shasta.
yeah, I believe you are new here. So, how is everything going in the department?
Yeah, so far so good. Everything is going well, doctor. Thank you for asking. And I'm really enjoying my, the rotations. But I'm about to start my labor duties now, and I was really intrigued to know about this CTG, which has been updated recently. So I am really, into the CTG now, and I really want to know about what is the use of CTG and what are the, the indications, contraindications, how we act on the CTG findings, and how does it help our system?
Yeah, sure, Andrew. I can see your interest, and it is really an emerging topic. And everyone who is working in the labor room, it is very important for everyone to know how to interpret the CTG. What are the indications? I really like your decision about learning CTG.
Thank you. Thank you so much.
So, do you have any background knowledge about CTG? Have you ever seen CTG
Yes,
before?
yes, I had seen in my foundation training, and since I'm in the ST1 now, so but at that time we were not allowed to do the anything. But yes, I know the basics that yes, we do have a machine and we do have transducers and we do have to apply it on the woman abdomen and then we have to record it. So this is what I know, but not the complete basics.
Yeah, great interview. I can understand you have a thorough knowledge about it. But today we will learn deeply. And anytime if you think I am very fast or you are not able to understand, please let me know. I will repeat for you. I will be more than happy.
Sure, sure, doctor, sure.
So, particularly, what do you want to learn? Indications or
Yes, indications, contraindications, and the how we interpret and how we do this. The in terms of management of patient as well. How do we
yeah.
apply CTG?
Yes, Andrew, now we can learn together.
Mm-hmm.
So, first of all, do you have any idea what is CTG? Simple definition.
Yes, yes. It's a graphical record.
Yes, you are very right. It is a
Uh-huh.
graphic recording of fetal heart rate and
Uh-huh.
uterine contractions. So there are
I
two
see.
components, uterine contractions and fetal heart rate.
Okay.
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 And before jumping to learn about CTG, there are some prerequisites. So we
Mm-hmm.
have to check that CTG paper is available, and we have to check the speed of the paper.
Mm-hmm.
It takes like 1 centimeter per 1 minute. We have to check, and we have to check its labeling, particularly
Mm-hmm.
name, age, and the
Mm-hmm.
time
All
at which
right.
time we are doing the CTG.
All right.
And
All right.
so, can you repeat any two factors which
Oh,
we have
yeah,
to
you said that, we have to check the CTG machine, we have to write the patient's name, age, and NHS number as well,
yeah,
and yeah, the time as well. Yeah.
yeah, great, Andrea. I can see you are a quick learner. I really
Mm.
appreciate it.
Yeah, thank you,
Uh,
doctor.
yeah. So, Andrew, do you think CTG is mandatory for every patient, or it is only for specific patients? Any idea?
Yeah, this is what we have heard, the read that it's not mandatory for every patient, and
Yeah.
it is just for the high risk individuals.
Very good. Excellent. So this
Okay.
CTG is only for high risk patients. Otherwise,
Mm-hmm.
we have to shift the patient for intermittent auscultation.
All
This
right.
is for low risk patients, intermittent auscultation. Whenever there are some problems on intermittent auscultation, we have to shift the patient to continuous CTG
Okay.
monitoring.
Okay. Got it. Got
Okay.
it. Mm-hmm.
So
Got it.
now we are going to the components of CTG, and there is a famous mnemonic for that. That is Dr. C. Bravado. Have you ever heard
Mm-hmm.
about that?
Yes, I did, but I don't remember now.
Yeah, no worries. We will learn together today. So in Dr. C. Bravado, DR is for the determination of the risk factors.
Mm-hmm.
For high
Okay.
risk factors, there are some risk factors like we have to check what are the risk factors, like if meconame is 10, like if we have augmented the labor, if this is
Mm-hmm.
breech delivery, or
All
if
right.
it is a trial of labor. So all these are high risk patients. So
I
this we have
see.
to check,
I
right?
see. Okay. Okay. Fine, doctor. Mm-hmm.
Okay, so now come to the second part of Dr. C. Bravado. So C is for contractions. We have to
Mm-hmm.
check the contractions. So
Okay.
come to the this, you can see this graph. The upper graph is for the heart rate, and the lower graph,
Uh-huh.
you can say this lower column, this is for uterine contractions. So
Okay. I
here we
see.
can see the like amplitude of contractions is straight. How many contractions per 10 minutes? We have to
Uh-huh.
count this. Okay.
Okay. Okay.
So, can you see this graph and tell me the number of contractions here in 10 minutes?
Uh, I don't think there is any contraction. Yeah.
Yeah, I can see maybe little bit, maybe this is a little bit artifact, or we can say
Uh-huh.
one
All
contraction in
right.
20
All
minutes.
right. Okay.
So,
Fine. Mild
still,
contractions. Yeah.
yeah, very mild
Mm.
contractions, right?
Okay. Fine.
So, and
Fine.
after that, after contraction, We have Dr. C. Bravado. B is for baseline heart rate, right?
Okay.
So now come to the upper column of this graph. This
Okay.
is
Here.
baseline heart rate. Normal baseline heart rate is between 110 to 160 beats per minute,
All
right?
right. Okay. Fine.
Anything above this or below this, it can be suspicious or it can be pathological. Okay.
Okay.
So now, according to new CTG, which is recently launched, in which now before we assume that if the heartbeat is between 100 to 110, this is suspicious. But nowadays,
Okay.
the terminology is changed. We can say now this is in the yellow zone.
Ah,
This
I
is this is
see.
the name of suspicious CTG,
Okay.
right?
Okay. Fine. So it is different than the previous one, right? What we have read, the
Only little bit.
reassuring features and non-reassuring features. So now we
Yeah.
are, we are giving them colors. Yeah.
Yes. Now this is only the change.
Ah. Okay. Okay.
Yeah.
Fine. Fine. Got it.
And
Got it.
if it is pathological, we can say now this is a red color or
Oh, I
amber color.
see.
We can
I
see
see.
this
I
is only
see.
color they changed. Otherwise, things are the same almost, right?
Okay. Okay. Fine.
So
Fine.
now
Got it.
here we can see how many heartbeats are in 10 minutes. So I think the screen is little bit blurred, but I can see this is normal. It is in white zone. So this is normal
Okay.
heart rate, right?
Okay.
This is in the right white zone. White means normal heart rate.
Okay.
Okay,
Fine.
this is in white color. And
Mm-hmm.
if it is in yellow color, then it would be suspicious. And if it in this amber color, then it would be pathological or abnormal
All
CTG.
right.
Okay.
Okay. Okay.
So this is
Fine.
this is a little bit change. And now come to the other component,
Uh-huh.
baseline Dr. C. Bravado. And after date, there is variability. Okay.
Okay.
So here I can see this is normal beat to beat variability. This is like 15 beats per. So this is normal. You can see these
Mm-hmm.
seesaw structures in between the
Okay.
heart
This
rate.
one. This one. Okay. Fine.
So this is variability, normal beat to beat variability.
All
Okay.
right.
And we have a component of accelerations. Okay. Acceleration is when heartbeat comes 15 beats above the baseline heart rate, we can say
Mm-hmm.
this is the acceleration. Its presence
Acceleration.
or absence doesn't matter, but
Mm-hmm.
if it is present, this is a reassuring sign. Okay.
Okay. Fine.
So here we
Fine.
can say there is no, yes, there are, I think, one acceleration here. We can see in the middle,
Mm-hmm.
one
Mm-hmm.
acceleration.
This one. Okay.
Yeah. So this
Fine.
is reassuring sign. Okay.
Mm-hmm. Mm-hmm.
And we have the next part. This is deceleration. Deceleration means when heartbeat comes down of the baseline heart rate, 15 beats uh, lower than the normal baseline heart rate. This is deceleration.
Mm-hmm.
Okay. So here we can see. Can you tell me how many decelerations?
Uh, I don't think there is any, right?
Yes, you are very right. There are no
Okay.
decelerations.
Okay.
Okay. So
Fine.
this is
Fine.
normal CTG. We can
Mm-hmm.
see. Okay.
All right.
And after that, and we have, there are three types of decelerations: early decelerations, late decelerations, and variable decelerations. Early
Okay.
decelerations are important whenever there are when head compresses. At that time, there is deceleration, but it is only because of postural change. When we change the posture of the patient,
Mm-hmm.
it
Mm-hmm.
comes normal. Okay.
Okay.
And if there is late deceleration, actually late deceleration is something abnormal when there is decreased blood supply towards the baby. In that case, there
Mm-hmm.
is late deceleration.
Mm-hmm.
And it is not a mirror image of contractions. Early deceleration is always the mirror image of contractions, but late deceleration, it comes in between, sometimes with contractions, sometimes without contractions. So
Mm-hmm.
in that case, we have to adopt some conservative measures like left lateral position. We have to give the
Okay.
IV fluids. We have to
Mm-hmm.
like sometimes we have to stimulate the scalp of the baby for
Mm-hmm.
management, and we have to inform the
Okay.
seniors, right?
Okay.
Okay.
Okay. Fine. Fine.
And there is a third type of deceleration, which is late deceleration. Okay. Late deceleration is always, sorry, not late, the variable deceleration. This
Mm-hmm. Mm-hmm.
deceleration is in between, means between the contractions and between the contractions and sometimes with the contractions. This is also pathological. It occurs whenever there is cord compression or when there is some pathology, right?
Okay, okay, fine,
And
doctor.
in that time, we have to check the patient. We have to check the vaginal examination if there is any evidence of cord compression. At that time, again, we have to adopt a preventive measures, right?
Okay, okay, fine, fine, fine.
And after that, the last component is O. O is the overall assessment. We have to write the remarks of the CTG, like whether this is normal CTG, this is suspicious, or this is abnormal CTG.
Okay,
Remarks related to CTG, right?
fine, fine. So, doctor, this is going to be the normal one, right? We don't have any deceleration, and heart rate is good, acceleration is there, beat variability is good. So this one is going to be normal, right?
Yeah, you are very right. This is normal
Okay,
deceleration.
fine,
Okay, because the
fine,
heart
fine.
rate, we can say this is in the white component of the CTG graph, right? And we already read all the things. There is one acceleration, no deceleration. So this is normal CTG.
Got
Okay.
it, got it. Yeah, yeah. Thank you, doctor.
So
Thank
now,
you.
how are you feeling now?
Yeah, feeling bit better because I was very, the anxious to know about all these colors because I am not familiar
Yeah.
with all these colors. Earlier, we used to have the reassuring and non-reassuring
Yes,
features,
you are
but
very
now
right.
now they have white, amber, and red color. Okay,
Yes,
brilliant.
you
Yeah.
are very right.
Okay,
So now,
okay.
next time, whenever there is a patient with abnormal CTG or suspicious CTG, definitely I will call you and show you the features of CTG graph at that time. Okay.
Okay, okay,
So,
fine. I appreciate.
so how was the session?
Yeah,
At
I think it was good. Thank you so much. You have been helpful, and really, I have learned. I have learned a couple of new things. Yeah,
yeah,
thank you.
indeed. It is really appreciated. And whenever you feel any difficulty, you have any problem with any topic, please let me know. I'm always here to help you and support you. And I'm going to give you some teaching materials, and we have a beautiful, nice guideline related to CTG. You can go through that. And you have any difficulty, please let me know. I'm always here. Okay.
Okay, okay, okay. Fine, doctor. Fine. Thank you.
Thank
Thank you.
you.
Thank you so much.
Thank you, ma'am.
Okay, so how do you feel? How was it?
Ma'am, actually, this amber color, white or yellow, I'm looking first time this CTG, and and this is the grace of the God that I got the opportunity, and I did this task with you. Alhamdulillah.
Okay, okay, that's good. That's good. Now let me ask other candidates. So how was it, Manikam? How did she perform? Sadia, Namono, Nagina, Mariam, Ishaq, Anam. How has she performed?
Doctor, she's passing. She's excellent. But just I want to comment on there is no acceleration. Is this acceleration or just it's not I mean 15 beats per minute, Doctor, right?
No, no, it's not. In fact, but it was okay, even if because she has told herself that the presence or absence doesn't define anything, but presence is reassuring. Okay, so yes, it is not the acceleration, but it's okay. It's fine. Yeah, this is nothing. This was, the loss of contact. This is loss of contact, and this was okay. Okay, very good, Kumari. Very good. Okay, Arwa. Annie, what do you think? Emmanuel?
Hi, I'm joined just late, so I couldn't manage to listen to the whole station. My
Oh, good
feedback
to
will
hear
not be.
from you. How are you doing?
Oh, I'm good. I'm good. Thank you.
Alhamdulillah,
Yeah, it's nice to
Alhamdulillah.
join your meeting again.
Thank you, thank you. I've been missing you.
I know, me too as well.
I hope you're doing good. Yeah.
Yeah, life is going
Okay,
on.
okay. Alhamdulillah, Alhamdulillah. It has to this way or that way.
Alhamdulillah. Yeah.
Yes, yes. Okay, brilliant. So, Shaista, so far many, the good reviews for you. So, I also think you did good. Okay.
Thank you,
But in
ma'am.
10 minutes time, of course, we cannot cover the whole fetal, the CTG. But you did, the brilliant in telling this. But I will suggest you don't go unnecessarily into the deceleration types. Okay, because deceleration types are itself, the very long topic. So of course, when we will go into this, we will be lost in that. Because what if candidate asks you that what is the cause of late deceleration? What is the cause of, the variable deceleration? So somehow then, of course, in 10 minutes time, we can't, finish it. So my suggestion would be that when you have started with this Dr. C. Bravado, so it is very good, okay, because this is the universal mnemonic what we follow for the CTG, right? So when you come to overall, so ask him. So what do you think, Andrew? I mean, what type of CTG is it? Because in O, we have to determine, we have to give the overall, the picture of this CTG. So what do you think? What type of CTG is it? So he will tell you that this is normal. So, oh, brilliant! You are very good. Yes, it is normal because we can see that the heart rate is quite good. This is stable heart rate 140, 140, and the beat to beat variability. You have to say beat to beat variability, however, that it is 5 to 25 beats per minute. Okay, so the less than, because beat to beat variability is the the important component in our CTG, because it is going to be only lost when there is no coordination with it, when there is not going to be any coordination between sympathetic and the parasympathetic activity of fetal heart. Okay, so this you have to, which I think that this you have to address properly. Okay, then
Right.
the deceleration, you can say the deceleration, we have got three types of deceleration. Okay, you can simply touch. I would suggest don't go into the depth of that. You can see deceleration is when there is downward peak in CTG in 10 minutes time, when it is 15 beats per minute down the baseline and it stays for 15 beats, 15 seconds, then we will term it as the deceleration. Okay, so likewise, you are going to say that this is acceleration, this is deceleration. Okay, beat to beat variability is very important to comment on, because this is going to, whenever beat to beat variability will go, our CTG is going to be bad, right? So yeah, you will build rapport, which you did very brilliantly. Hello, I'm Dash the registrar, and you are okay. Situational awareness, exclude bullying. How's everything going on? Everything is good. Confirm the scope of meeting. I think you are the one who want to learn about CTG. Is that correct? Yes. So how is it going so far? Be reassuring and gentle. Smile quite often. Okay, because you are talking to your junior, so make a, the very pleasant personality. I mean, present yourself a very, the pleasant one. So smile quite often. Okay, it is important. So be very natural, be very flowy. Ask about the background knowledge, set agenda and scope of discussion. What do you want to know about CTG, which you have asked brilliantly? Have you ever seen any CTG before? Yes, I have seen, doctor, but I have not seen according to the new, the criteria, because I have been seeing people around that they have been talking about the new criteria and all. Okay, brilliant. So I will definitely, or you can say, I will surely discuss about it. Okay, then may I know what are you, why are you interested in this topic? What do you expect to from this session? Ask concerns. Okay, so today we will discuss the basics of CTG and discuss the CTG you have. Okay, because he has brought the CTG. Okay, which is normal apparently. Then you will say CTG. Yes, you have asked that it is an electronic, the fetal heart rate. You will say that look, Andrew, we do have couple of ways by which we do check fetal heart rate, like we do have handheld Doppler, we do have Pinard stethoscope, but CTG is electronic way to record, which we do externally. However, we do have internal monitoring as well, like fetal scalp electrode and intrauterine pressure catheter device as well. Okay, this is what we do. Okay, internal monitoring and external monitoring. Internal monitoring is fetal scalp electrode and intrauterine pressure catheter. This we don't do, the quite oftenly. Fetal scalp electrode sometimes we do if we feel that our CTG external monitors are not, the properly placed on the woman abdomen. So external fetal monitor is what we do. So you can quickly touch. Okay. So you will say that it will record the changes in the fetal heart and their relationship to the uterine contractions. So the aim is going to be that we have to check then when the baby is short of oxygen, in the hypoxia, to assess the fetal well-being. Okay, then it is going to determine, because this you have to tell him that why we do the CTG, because we have to check, or you can simply say we just need to check that whether baby is in danger or no, whether we have to deliver the baby on urgent basis or no. Okay, so this is going to help us in assisting the the delivery by the any the cesarean section, or by any instrumental vaginal delivery. Okay, so this we have said, you have said brilliantly that we have to check the speed. So yes, when you are telling speed, So side by side, say they do have two types of speed of the paper as well, 1 centimeter and 3 centimeter. Okay, so 1 centimeter is for the low risk patients, but 3 centimeter is going to go for the complicated cases like IUDR, in which we need to see the baby's heart rate quite closely. Okay, CTG machine should be checked and it should be correct. Any the other acute events should be noted, like after vaginal examination, after epidural, patient should be in left lateral, her bladder should be emptied. Okay, to avoid any hypotension and disruption in the venous return, and it should be labeled with name, age, NHS number. After this, you are going to ask him, can you please repeat for me that what we have discussed, what is important? So he will tell you 1, 2, 3, 4, 5, 6, the things. Okay, brilliant, very good. So after checking this, we are going to do the indications and all. Okay, so CTG can be done, can be of number one, baseline CTG before induction. It can be intermittent CTG that we will do, and we will remove it, and then it can be continuous CTG as well. Okay, so then we are going to talk about the indication of continuous CTG monitoring. Okay, if a mother is having temperature, if a mother is having hypertension, or if there is prolonged labor, if mother is on the induction of labor, then after that we are going to have the oxytocin use. If patient is going for the previous cesarean section, so this is how we are going to put them on continuous CTG monitoring. Okay, so Andrew, can you please repeat some indications for me? Okay, fine. So if he does, very good. If he doesn't, no, it doesn't matter. So what is the advantage? Advantage is that it may predict the neonatal outcome, okay, or it may decrease the neonatal seizure activity according to the guideline. And disadvantage is that it may have high false positive rate, and it may have the interpersonal variability in interpreting the CTG as well, which can end up in having unnecessary cesarean sections as well. Sometimes the disadvantage is that possibility is that women not on the center of a care on the labor room, and sometimes there are going to be unnecessary cesarean sections and instrumental births. Okay, so that's why we need to take everything into account when we are interpreting the the CTG. All right, so the following systematic approach we do, Dr. C. Bravado. So this is defined risk. So we are going to see that why we are going to do the CTG. Okay, then we are going to do the baseline rate. Then we are going to check the acceleration. Baseline rate is going to be when the trace is going to fall and consistently in the same baseline. Okay, like in this CTG, we can see that the trace is on 140 beats per minute. Can you see this, Andrew? Oh yes, I can see. Brilliant, brilliant. So our baseline rate is, let's write it down. It is 140, right? Then we will see acceleration. Do you know what acceleration is? Well, I don't know. So we do define acceleration when there are, from the baseline, there is upbeat of the the heartbeat for 15 seconds, and it stays for 15 15 beats per the minute upstroke, and it stays for 15 seconds, and then it will come down. It is acceleration, and deceleration is equally opposite to acceleration. Okay, okay, so can you please repeat for me? Okay, fine. So can you see any acceleration? No. Do you have any idea of what acceleration will show? No, doctor. All right, so let me tell you. So acceleration is the reassuring. Presence is reassuring, but absence doesn't mean the CTG is bad. Okay, all right, okay. But deceleration needs the further input, and we need to look at the complete picture. Complete picture means then we have to look at the patient, her laboring position, her acute event, anything. Okay, then we are going to check the contractions, that I know how many times a woman is contracting in the 10 minutes. Do you know what are the normal contractions in 10 minutes? Maybe two. No, I'm afraid, Andrew, they are 4 to 5 in 10 minutes. Okay, all right, according to the new CTG. Oh, all right, good. So can you see in this CTG? No, doctor, I don't. Okay, so 140 beat and beat to beat variability means the heart is the contracting with good beats from 5 beats to 25 beats per minute. Okay, so this is very good. This reflects a good sympathetic activity of the heart. So if it is lost, so it means baby is in danger. Then we have to look at the complete the scenario as a whole. Okay, the patient, any acute event, the time she is admitted in labor ward, and the everything. All right. So this is variability. So 5 to 25 is good. Anything below than 5, anything above than 5, it needs, the attention. Okay. And then deceleration, what I have told you. All right. So in this EKG, we can see that 140 beats per minute. There are no contractions. There is good beat to beat variability, and there is no deceleration. So what do you think this EKG is? Oh, it looks normal. Yes, very good. So this is O in our, the Dr. Bravado. Okay. So overall impression is this is new CTG. Now let me tell you that, the how do we interpret the CTG? So we will determine the CTG on the basis of features, and then we will, give them the color. We will code them with color. One is white, one other is amber, and then is red. Okay. So contractions, if less than 5 contractions in 10 minutes, it is white, means normal. Baseline heart rate 110 to 160 beats per minute, 5 to 25 beats per minute. Deceleration, no deceleration. Okay. Either there are early deceleration or variable deceleration, but there is no concerning characteristics. Okay. So this we can discuss in another setting, Andrea, because it requires a lot of the understanding. Okay. Oh yeah, I got it. Okay. So for amber, 5 to more contractions in 10 minutes, it is amber. Increase 20 beats or more from this the start, 100 to 109 beats per minute, or we are unable to determine the baseline risk. Variability, if there are less than 5 or more than 25 for 10 minutes. This is completely different from, the previous CTG, Andrew. Okay. So we have to be very careful now, because we are going to study this CTG in our curriculum. All right. And likewise, we are going to memorize all these, the features in deceleration. However, red is going to be the alarming zone. Okay. We are not going to count the contractions, but we are going to count the baseline heart rate if it is less than 100 or more than 160, or if the variability is less than 5 for more than 50 minutes, or more than 25 for more than 10 minutes, or if there is sinusoidal pattern. Okay. Or there are deceleration present as well, or there is acute bradycardia for 3 minutes or more. So this means red means now we are going to categorize our CTG. Okay. If CTG is normal, we are going to continue the same, the monitoring, or we can put the woman on intermittent monitoring. If it is suspicious, we may commence conservative measures, like we will put the woman on left lateral position, oral or IV fluids. In case of hypotension, stop oxytocin, consider tocolysis, which is terbutaline 250 micrograms subcutaneous stat. If CTG is pathological, we may offer fetal scalp stimulation after implanting conservative management. Okay. If CTG is still pathological, then we will expedite the birth. Okay. And now, Andrew, let me tell you, now there is no role of fetal blood sampling. Okay. Now we are not talking about fetal blood sampling in new CTG. All right. Okay. Okay. Fine. So, if time allows, you can, repeat all these things. If time doesn't allow, so you can even limit your, the complete consultation. Dr. C. Bravado. Okay. Shasta, are you there?
Yes, ma'am.
Okay. So you can simply tell him as well that, how we define all these things, that, if there is amber color, if everything is fine, white, it is normal. If only one amber, okay, and the rest 3 are white, so it is going to be suspicious. If the any one red column is there, or 2 amber color are there, it is going to be pathological. So then we are going to follow this the pattern. Okay. So of course, then you are going to close the loop. You are going to give him the fetal monitoring NICE guideline, and watch YouTube videos for basic understanding of CTG interpretation, because this we all need as well, basic understanding how to read CTG. Okay. That what are the number of columns, and how many beats are in the small column and in the large column as well. Okay. So for this, even we as a med exam expert, we do have a very beautiful CTG teaching session by Dr. Dizeri as well. Okay, so you guys can go to the YouTube, and you guys can, listen to that CTG lecture. I hope it is going to be very helpful for all of you. Okay. So clear, everyone? Any question? But otherwise, Shaista, overall it was very good. So I will suggest keep the same pace and discuss, and do try to perform more. Okay.
Thank you very much. So kind of you, ma'am.
Good job. Okay, great. Any question, guys? Any question? Please share the name for YouTube CTG lecture. It is CTG. Okay. It is understanding the CTG, I think. Okay. So while you will open YouTube, you will go to Med Exam Expert, and you will go through by Dr. Dizri. Okay. Yeah. So go through it. Okay. It will help you because she has explained everything. And there is one lecture as well, I think, another lecture on the CTG as well. So this way you will learn. Okay. So make sure that you are memorizing this by heart. All right. You can take picture of this, the slide as well. You can go through, this. So make sure that you are memorizing everything by heart. Okay. So this is completely different from old CTG. Okay. Now we do have color. We have coded them. Earlier we had, the reassuring features, non-reassuring features. Okay. Now we don't have a such thing. We have only white column, amber column, and red column. All right. Great. Any other question from any part, anywhere from part 3?
So I have a question about the CTG, if that's okay with you. So
Yes.
like we are expected to get it as a teaching session.
Yes.
And it will be like a case scenario, assuming that it could be a normal CTG, it could be abnormal CTG.
Yes.
So what kind of abnormal CTG, let's say, to go for? Because there's a lot of abnormal CTGs, if you understand what I mean. Is it like more of the variable deceleration explanation, more of deceleration? What kind of thing that we...
So what I have noticed so far, they have kept one time normal one, the same, okay, which I have kept today. And one time, I think it was suspicious CTG with, the 1 or 2 amber colors. So this is what you have to pick. You have to tell that, okay, but this is what I believe, that usually they are not going to bring so many abnormalities. They are more interested in your way of teaching plus, the normal one. Okay.
Okay, I see. Yeah, because it will be very much lengthy if we go to the abnormal one.
Exactly. It is going to be very lengthy because deceleration itself is a very big topic. Because what if somebody asks us, okay, what are the causes of late deceleration? What are the causes of, the variable deceleration? What is prolonged deceleration? So this itself is a very, the big topic. So of course we can't discuss everything in that, the particular one setting. So the idea of teaching session is that you follow the same, the template. Okay. You need to be very friendly. You need to smile a bit, and you have to teach. You have to involve. Involvement is very necessary. Plus, you have to give, the recommended sources. You have to give him, the proper sources as well about this, the particular. If we are talking about CTG, so yeah, there is nice guideline, fetal monitoring nice guideline that came in, I think, December 2022. So this is pretty new. All right. So, oh yes, apart from that, I will advise all of you to go through labor care guide as well. Okay. Labor care guide, new labor care guide. All right. Because now we are not doing partogram, but we are working on a labor care guide. All right. So I will send you, Arwa, don't worry. Okay. I will send you labor care guide so you can read more about it. And because that is important now.
Thank you very much. Thank you.
Welcome.
Dr. Zaib, what about fetal blood sampling?
Sweetheart, now there is no role of fetal blood sampling in the new guideline. Okay. They are not talking about fetal blood sampling anymore.
Okay.
All right. So I will suggest you don't even bring whatever is not discussed in new guideline. Don't even, touch that point. Okay. Yeah. There is no role of fetal blood sampling anymore. Okay, because the new guideline only talked about the fetal scalp stimulation, FSS. That's it. All right, great. Any other question? Mariam, any question? Nagina? Sarika, Sadia, Shinta, Shivkumari. No? All right, all right. So I hope I have been helpful. Yeah.
Excuse me, Sadia here.
Yes, Sadia.
Ma'am, CTG as a teaching can come in an online pattern as well?
Anywhere, sweetheart. It is very important topic. Okay? So remember that because since we have new CTG, so RCOG expects every candidate that they are well versed with CTG and labor care guide. Okay?
Okay, all right, ma'am. Thank you so much.
Okay, okay. Deceleration slide. Okay. This is deceleration. You guys can take picture as well. Okay, no problem. So study hard, work smart, discuss every day. Okay, revise your syllabus because there are the couple of new guidelines as well. So make sure that you guys are working on everything. Okay, and presentation is what that matters. Okay. All right. Any other question?
Thank you very much. That was really great. Thank you.
Welcome, sweetheart. Welcome. So prepare for your big day, guys, and ace it. Okay. This is a very big day for every the candidate going to the RCOG and getting your certificate. So this is kind of the dream come true. So all the very best, guys. So anybody who needs help, my help, okay, I'm always available. I'm open, okay. I'm freely available everywhere, right? I'm on Facebook, I'm on Telegram, I'm on WhatsApp as well. So anybody who wants, any kind of help, any suggestion, anything, I'm open for it, okay.
As usual, you're always approachable. Thank you very much.
Thank you so much. Thank you so much. Okay, guys, see you some other time. I will because many candidates are requesting me to go for another session close to exam. So you guys need to write to me that which module you want and which station you want. Okay, so because it really takes time to prepare for any session, so I will definitely do that. All right. So you guys can join our Telegram group. You guys can write to me in person as well. So approach to me, tell me which station do you guys want to practice from any module there is. So I will try to help as much as possible, inshallah. Okay. Okay, the rest of our team is available 24/7. Okay, and of course you guys can approach to us. And yes, I am open for mocks as well for May exam. Okay, so if anybody wants to book, you guys can book with me. So we will discuss. All right.
Ma'am, what are the dates of the mocks, ma'am?
Sweetheart, that is going to be decided mutual understanding between candidate and me. Okay.
Okay, so we can
Yeah.
just do a personal message for you.
Yes. You can personal, the message. You can message me or my team member, and inshallah I will guide you through. Okay.
Okay, thank you so much, ma'am.
Okay. Welcome.